Hello, everyone, and welcome to today's webinar, Insights into Evidence-Based Practice to Achieve Best Clinical Practice in Ultrasound Probe Reprocessing. Before we get started, I'd like to go over a few items so you know how to participate in today's event. You've joined the presentation by listening through your computer speaker system by default. If you prefer to join over the telephone, just select Phone Call in the audio section of your control panel, and the dial-in information will be displayed. You can submit text questions at any time by typing them into the questions box of your control panel. We will address them later in the presentation. Here is the overview of today's presentation. Medical teams today use evidence-based practice, EBP, to be effective in changing clinical practice in ultrasound probe reprocessing. They need to have a comprehensive understanding and knowledge in their decision-making process of how to critically analyze and review peer-related published research to obtain best research evidence. Without the best research evidence, you are only a person with an opinion. The learning objectives are what is evidence-based practice? Why is evidence-based practice important? What happened before evidence-based practice? Not all published research is of sufficient quality to inform clinical decision-making, and how HPV research evidence has been used to support clinical change in ultrasound probe reprocessing. And now I'd like to introduce our two presenters for today, Dr. David Weber and Dr. Craig Myers. Our first presenter, Dr. David Weber, is a professor of medicine, pediatrics, epidemiology, associate chief medical officer, UNC Hospitals Director, medical director, hospital epidemiology. Dr. Weber is a board certified in internal medicine, infectious disease, critical care medicine, and preventative medicine. His research career has focused on healthcare associated infections, antibiotic stewardship, new and emerging diseases, and vaccine implementation. Dr. Weber also chairs the North Carolina Department of Health. Our second speaker is Dr. Craig Myers, the Distinguished Professor of Microbiology and Immunology and Obstetrics and Gynecology, Director of the Training Program in Viruses and Cancer, Penn State College of Medicine. Presently, the central research goals of Dr. Craig Myers' laboratory are to study the differentiation-dependent life cycles of HPV. His team is the first to grow native, natural infectious HPV in high enough quantities for laboratory testing. He has published several research papers on disinfectants commonly used on ultrasound probes. These studies are also demonstrated the clinical importance of using native HPV for disinfected and microbiocide testing in contrast to surrogate viruses and virus-like particles. Thank you. And now, David Weber, thank you.
Thank you very much. It's a pleasure to be presenting this information that I think should be of great interest to all of you. So what I will be talking about is how to integrate scientific evidence into best clinical practice. Next slide. And we're going to start off with a background, the rationale for high-level disinfection of ultrasound probes. Next slide. So what happened before we had evidence-based practice? Well, before that, health professionals relied on advice of more experienced colleagues. The advice was often taken at face value, their instincts, and what they were taught as students. We may wonder why the practice of bloodletting persisted for so long, especially when research in the 16th and 17th centuries exposed substantial errors. It continued to be based on traditional teaching rather than evidence-based research. But what will physicians think of our current medical practice 100 years from now? They may be astonished at our overuse of antibiotics or the way we reprocess ultrasound probes between patients. Evidence is subject to flaws of bias, experience that is, and what we learn as students can quickly become outdated. Relying on older, more knowledge colleagues as a sole source of information can provide dated, biased, and incorrect information. That's not to say that clinical experience is not important. In fact, it's a crucial part of the definition of evidence-based practice, which I'll abbreviate as EBP. However, rather than relying on clinical experience and decision-making only, healthcare professionals need to use a clinical experience together with other types of evidence-based information. Next slide. So why is evidence-based practice important? EBP is important because it aims to provide the most effective care that is available with the aim of improving patient outcomes. Patients expect to receive the most effective care based on the best available evidence. It promotes an attitude of inquiry in health professionals and starts us thinking about, why am I doing this way? Is the evidence that can guide me to do this in a more effective way? As health professionals and part of providing a professional service is ensuring that our practice is informed by the best available evidence. EBP also plays a role in ensuring that finite health resources are used wisely and that relevant evidence is considered when decisions are made about funding health services. Next slide. So now let's turn to healthcare-associated infections, which are abbreviated as HAIs. Reducing ultrasound probe cross-infection risk can aid in reducing healthcare-associated infections. Evidence-based systems are used to prevent and control HAIs. In the United States, an estimated 5 to 10% of hospitalized patients will experience an HAI every year, resulting in substantial morbidity and mortality. The European Centers for Disease Prevention and Control reports an average prevalence of 7% in European countries, as you can see, quite similar to that in the United States. In a European multi-center study, the proportion of infected patients in an ICU can be as high as 51%, and most of these are healthcare associated. Approximately 30% of patients in an ICU are affected by at least one episode of healthcare associated infection. This results in a longer stay in the ICU, and those with a longer stay in the ICU are more at risk since it's based on time. On average, the cumulative incidence of infection in adult high-risk patients is 17 episodes per 1,000 patient days. High frequency of infection is associated with the use of invasive devices such as central lines, urinary catheters, and ventilators. Next slide. Reducing ultrasound probe cross-infection risk, as I said, can reduce HAIs. Prevention of HAIs is a top priority globally for different departments of health, and HAIs are a focus of multiple national and state reporting requirements and prevention initiatives in the United States and across the world. Up to 70% of HAIs are preventable using existing infection control practices, and this is a very important point that most of these infections are preventable. Infectious transmission occurs due to inadequate cleaning, inadequate selection and use of the disinfecting agent, and failure to follow recommended cleaning and disinfection procedures. And this refers specifically to probes that we're talking about. Next slide. So, reducing ultrasound probes again can result in reducing HAIs. Patients are 41% more likely to have a positive bacterial culture 30 days after a transvaginal scan where the probe was low-level disinfected, and 26% more likely to be prescribed antibiotics, both suggesting, in fact, that the low-level disinfection led to infection, which led to antibiotics. MHRA alert released due to a patient death from hepatitis B infection due to improperly reprocessed transesophageal echocardiography probes. So here's an example of failure of proper cleaning and disinfection to lead to a serious infection. Next slide. More than 80% of probe handles that are not disinfected had residual pathogens. Up to 10% of condoms and barrier sheaths that are used to help prevent contamination of the probe leak. Therefore, it's a critical point to know that their use does not replace the need for high-level disinfection. Up to 70% of ultrasound probes were found to be contaminated with human DNA and HPV DNA after disinfection with low-level wipes. Next slide. Here are just some of the outbreaks associated with transesophageal ultrasound probes, and I'm not going to read all of these cases, but the top one in England, death of a patient due to hepatitis B, may have been associated with failure to appropriately decontaminate the probe, even though there was a probe cover used. In Belgium, 42 patients were colonized or infected. Mortality rate was 40% among infected patients at a very large cost. Another example is a healthcare-associated outbreak of Legionella caused by contaminated transesophageal echocardiography. We have another example of an increased incidence of Enterobacter in a cardiovascular ward, again, due to failure to properly disinfect transesophageal ultrasound probes. Going down, then you can see cases of Serratia marcescens, an outbreak of Pseudomonas aeruginosa. All of these were traced to improper use of contaminated ultrasound gel or improper disinfection of transesophageal ultrasound probes. Next slide. And here are examples of problems and outbreaks related to improper disinfection or use of rectal ultrasound probes. Again, on the top, you can see an example of one patient affected by hepatitis C, another case of possible HIV transmission. Going down the list, you can see infections related to non-tuberculous mycobacteria, Pseudomonas cepacia, so an outbreak of Acinetobacter, and then Burkholderia. Again, a whole series of pathogens all related to the same problem, either use of non-sterile equipment or supplies such as non-sterile gel, or failure to perform adequate cleaning and high-level disinfection of an ultrasound probe. Next slide. Now we go on to vaginal probes, the same issue. You can see here data from Hong Kong, France, Spain, in multiple different studies showing that when you, despite using a probe cover, when you use cleaning and only low-level disinfection, a number of those probes are positive, most importantly for human papillomavirus, a major cause of cancer, of cervical cancer. But then you can see we have other problems as well, such as mycoplasma, Staph aureus, infection, or being found on the probes, again, despite appropriate probe covers and low-level disinfection. So again, we need to emphasize proper cleaning and high-level disinfection. Next slide. Here is a computer model of how important and what type of risk this represents for an entire country if you use low-level disinfection on endocavity probes. So the goal of this simulation study was to model what would happen if you used only low-level disinfection in France. It was a stochastic Monte Carlo simulation. What were the results? HIV, we would have 40 new HIV infections each year in France by using only low-level disinfection. For other viral diseases, an enormous burden, meaning roughly between 1,600 and 15,000 infections of other viral diseases just in one country. Again, the conclusion, we need to follow guidelines such as the CDC for high-level disinfection of all ultrasound probes. Next slide. So as we talk about the differences between what high-level disinfection accomplishes, this little schematic demonstrates that. So for sterilization, that is defined as the complete elimination of all possible microbes. High-level disinfection will eliminate all microbes except for high numbers of spores. It will eliminate low numbers, but not high numbers. But it will kill off all the mycobacteria, all the viruses, enveloped and non-enveloped, particularly important for rectal and vaginal probes as HPV. It will eliminate all the fungi and all the bacteria. Next slide. So here we have the classic Spalding scheme, which bases what type of disinfection sterilization you do on how the item is used. If the item is used to contact sterile tissue or an implant like a cardiac pacemaker, it should be sterilized. That kills everything. If the item is used to touch a mucous membrane or non-intact skin, then all you need to do is high-level disinfection, but you must do high-level disinfection, which will eliminate everything except high numbers of spores. If the item touches intact skin, then you just need to do low-level disinfection that will kill vegetative bacteria, some fungi, and envelope viruses, but would not kill mycobacteria, spores, and may not kill non-envelope viruses. So this is the scheme that's widely used around the world to determine what type of sterilization as disinfection is used, should be used based on the use of a device. And probes are semi-critical devices because they touch mucous membranes. Next slide. And again, this is just another way of looking at what we just said, going from non-critical to semi-critical to critical. Non-critical items touch intact skin, and therefore we only need low-level disinfection. Semi-critical items contact non-intact skin, such as a burn, a wound, or a mucous membrane. There, it's critical to use high-level disinfection that eliminates everything except very large numbers of spores. Critical would be contact with sterile tissue, body fluids, bloodstream, such as an implant or an intravenous catheter, and those need to be sterile, completely devoid of any microbial pathogens. Next slide. So what has the global response been with an increase in publications of guidelines? So we have multiple guidelines from multiple countries that appropriately follow the Spalding classification. That is, ultrasound probes must receive high-level disinfection. Of course, the CDC guideline, of which I was a co-author, came out in 2008. It's being revised now. But then you can see similar guidelines from many, many other countries. You can see the BMUS guideline in England, the Hospital Infection Society guideline, one in 2017, 2018, therefore several years old now. But you can also see guidelines from Canada, Australia, Germany, France, many of the countries in Europe. But not only them, but you have countries such as Saudi Arabia, the World Federation of Ultrasound, and others, all agreeing that probes need to be high-level disinfected. Next slide. Now I'm going to discuss the rationale for high-level disinfection of endocavity probes based on the best available evidence. Next slide. First of all, we need to assess, is the published research of good quality? So not everything you read in any journal that's sent to you is in fact of good quality. So not all research should inform clinical decision-making. Therefore, you need to critically read every single article and use that to inform your clinical decision-making. There are three aspects of evidence you need to look at. Validity. So is the article accurate and can you trust it? Impact. Are the results clinically important? And applicability, that is, based on what they said, is it in fact feasible and possible for you to translate that to your patient? EBP hierarchies rank study types based on the rigor, strength, and precision of their research methods, and different hierarchies exist for different question types. And some experts will disagree on the exact ranking of the evidence hierarchies, but here is one for you to the right. We'll talk more about that in a minute. And essentially what you see at the top are systematic reviews, where they use a defined method to review all the available literature that's best informed on appropriate, well-designed clinical trials. But that should also be based on appropriate non-human research in laboratories and others. Certainly we do that for drugs. We want to know pharmacokinetics. For disinfectants, we want to know, based on the laboratory, how effectively it kills, and the disinfecting devices are the same. Next slide. So again, here is the hierarchy. Again, at the top of the hierarchy are systematic reviews that would review all the relevant clinical and non-clinical evidence and studies. So for clinical studies, the best studies, of course, are randomized clinical trials. Less valid are cohort studies, although if they're well-designed, they can be very informative. And underneath that is case control studies. And below that is expert opinion. As a separate hierarchy, which people have not really made, are well-designed basic science studies. What we've learned in the laboratory, as I've already mentioned, for drugs, things like how the microbe is killed and pharmacokinetics. For disinfection devices, you obviously want data. Does that device kill the pathogens of interest, and does it do so in a realistic time frame? Next slide. Now, what is the rationale? We're going to move on to the rationale for high-level disinfection of endocavity probes and give you some actual data. So next slide, please. So first, we have to demonstrate the efficacy and effectiveness of a disinfectant or device for disinfection. Efficacy means a study that's done under ideal circumstances. In a clinical trial, that's a randomized clinical trial. Effectiveness means how does it work in real life situations? So we want to demonstrate that a disinfectant or a device inactivates microbes that you would inoculate onto a surface of medical devices. And then the key thing for the disinfectant or the device is the antimicrobial spectrum. What does it kill? Obviously, for vaginal and rectal probes, it must disinfect things such as gonorrhea, syphilis, HIV, sexually transmitted agents, but certainly also HPV. The speed, how quickly does it work? We want a disinfectant or a device to work in seconds or at most a few minutes. We don't want disinfectants and devices to take minutes to hours to work. And then how many logs does it kill, which is part of the definition of high-level disinfection. And we then move on to, we want to not put it on an artificial surface. We want to show that this disinfectant device will actually inactivate microbes on actual healthcare environmental surfaces or medical devices after use. So not just laboratory, but we want to prove that on real life ultrasound probes, a disinfectant or a device works. And ultimately, we would like to show that the disinfectant or device will reduce healthcare associated infections. That will require a large clinical trial, although in the place of very large trials, because they're expensive, difficult, and time-consuming, modeling can be used to provide evidence of effectiveness. Next slide. So let's start off first. What are we aiming for? What's the ideal disinfectant or device? Broad spectrum, that is, kills all the relevant microbes. Fast acting, we already mentioned. Non-toxic, so it's not dangerous to the user, the patients, or the visitors there. In addition to not harming people, we would like it to be safe for the environment. It needs to be compatible with the device you're using and not damage or degrade the plastic metal that the device is made of. It should be simple to use, ideally, just for a device, just put it in, push a button, and you're done. Obviously, disinfectants are a little more difficult because they're not really easy to use. You have to have contact with the disinfectant with every surface. There should be a means of actually validating that your device or your disinfectant really is working. Acceptable odor, color are important. And then finally, everything being equal, you would like to use the most cost-effective method. Next slide. So, what technologies do we have for high-level disinfection of endocavity ultrasound probes? We have ultraviolet light, which we'll abbreviate as UV. The advantage for this, of course, is it's totally chemical-free and perfectly safe for the environment. We also have hydrogen peroxide mist, and this is used as a 35% hydrogen peroxide, and this is a chemical agent, much like a chemical disinfectant, but in this case, it's a mist that would coat the item. Next slide. So let's talk and focus first on ultraviolet light here. Ultraviolet light is a high-level disinfectant as the particles and waves are reflected from the walls of the chamber to cover the surface of the probe. And this is done at a germicidal wavelength of 254 nanometers. So at this wavelength, the energy of the photons penetrates cell walls of microorganisms, all microorganisms. It's absorbed by DNA, RNA, and the proteins, essentially destroying them and leaving them unable to perform their cellular functions, and therefore that pathogen is no longer capable of causing human infection. Ultraviolet light is used widely in a variety of different ways in hospitals and medical facilities. It's used for disinfection of water to prevent Legionella. It's used in disinfection of air in either operating rooms to purify the air or to prevent transmission of TB. It's widely used for surfaces. So when a patient with a multi-drug resistant pathogen leaves the hospital room, it's used to disinfect the hospital room. It's used for disinfection of hearing aids. And these are only some of the many uses well established of ultraviolet light. Next slide. Well, here was a study about that looked at the ability of ultraviolet light, and here we're saying ultraviolet light C, which is that germicidal wavelength I've already mentioned, to disinfect intentionally contaminated anesthesia probes. 15 probes were exposed to non-sterile ultrasound gel, and then not only in the gel, they put a large inoculum containing known pathogens, Staph aureus, E. coli, Enterococcus, and then they left the gel on. They didn't just immediately disinfect it. They let it dry for a while. All of these things making it more difficult to disinfect. The probes were wiped dry with a paper to remove the gel, and they were wiped repeatedly until the gel was visibly removed. And then they were wiped with a disinfectant impregnated paper. The probes were placed in a UVC decontamination chamber by Germatech and exposed for only 90 seconds. After UV exposure, all probes were contaminated. Sorry, it should be before UV exposure. All probes were contaminated. After UV exposure, all the probes were disinfected. So there we have demonstration that the UVC was effective in eliminating disinfection. Next slide. Need to review research references used in research papers. Are they relevant or do they add bias? For example, the infection prevention control of ultrasound, a guidance here that's listed here. The guidelines reference to a research paper talks about room disinfection and compares room disinfection processes and the methods to ultrasound probes reprocessing. This is not a fair comparison. It's apples and oranges, and it adds bias. Hydrogen peroxide vapor or UV light for room disinfection has an entirely different purpose and methods compared to ultrasound probe reprocessing for probes. And so the ultrasound probe reprocessing disinfection method is delivered in a very controlled environment, a closed environment where distances are not measured in meters, but they're measured in millimeters or centimeters. And the intensity, since intensity falls off as a square of distance, is totally different. So one can't look at the data for disinfection of surfaces and make any conclusions about the use of a closed area for disinfecting probes, and the reverse is true. The really two need to be viewed. The data needs to be reviewed separately, analyzed separately. Next slide. Well, has the correct research methodology been used? For example, in the Munster article, the study described in this article is clearly invalid from a scientific viewpoint. While all studies on disinfection systems, notably ultrasound probes, are done with quantitative microbiologic analysis, meaning you actually count the killing or elimination, the discussed study only used the quantitative method, yes, no, which is often done in pharmaceutical research, but is invalid for the evaluation of semi-critical medical devices. The discussed study found more contamination after disinfection than before disinfection, which could have really no basis in science. This alone shows that the study design was inappropriate and did not have scientific value. In some cases in our study, bacteria, they said, were found in the second swab taken after disinfection, which were not found in the first swab before disinfection. So this tells you that somehow in their methods, they're actually contaminating the probes. Certainly a disinfectant, one could argue about how effective certain disinfectants or devices are, but you should never find higher numbers after disinfection than before, unless in your scientific method, you're actually contaminating the device. So this study has fatal flaws. Next slide, please. And here I'm going to turn over the presentation to my distinguished colleague, Dr. Craig Myers.
Thank you, Dr. Weber. So we're going to narrow down this next part of the discussion to some basic laboratory studies and focus in on human papillomavirus and how we tested different disinfectants to see whether or not they could kill or deactivate human papillomavirus. So we're going to look at the best research evidence that supports clinical change in ultrasound probe reprocessing. Next slide, please. Okay, so this part of the discussion is human papillomavirus, best research evidence. has played a critical role in effectively changing clinical practice in reprocessing ultrasound probes. Next slide, please. So a little background on me and my lab. I was the first ever to be able to grow natural high risk, that is human papillomavirus that is associated with causing cancer. I was the first able to grow stocks of infectious natural virus in the laboratory. And this was a critical result because it allowed us then to start testing human, ways to prevent human papillomavirus infection, including the use of disinfectants and their efficacy in killing papillomavirus. We've published hundreds of articles based on these studies, and the bulk of our articles focus on two types, HPV-16 and HPV-18, which, as you know, cause 70% of all cervical cancer and many other anal, genital, and oral pharyngeal cancers. Next slide, please. So we have published several papers that support evidence-based practice to integrate HPV research findings with clinical expertise and best clinical practice. We published research that tested HPV against many common disinfectants and showed that many disinfectants are not effective at killing HPV. And I want to point out here that many of the disinfectants that were labeled as high-level disinfectants, we found did not kill HPV. And this is because nobody had ever been able to test these disinfectants in the past. It wasn't until we were able to provide these high level stocks of infectious HPV to do these studies. These research tests include publications that showed that the Trophon EPR device and the Antigemix AS1 version 1 and the Kronos AS1 version 2 are proven to kill both HPV-16 and HPV-18 in vitro laboratory studies. So our HPV studies provide best evidence-based research to help clinics to mitigate HPV transmission risk from ultrasound probes. Next slide. So this is the basic protocols we have used. We've done a few studies using what we would call the suspension test, which is really just taking a small tube and mixing the virus with the liquid disinfectant that we wanted to test. And this can provide some basic evidence on whether the disinfectant can work or not, but it doesn't really recreate the situation that you would see in a clinical laboratory or a clinical institute. And that's where we come to the next part, where it's the carrier test, where we have these discs, and the discs are made of the same material that the ultrasound probes are made out of. And so this provides strong evidence that we can actually put the virus onto these discs, onto the same material that is being used in the ultrasound probes, let it dry, treat it with a disinfectant, and then recover the virus. And we know that without treatment, we can recover all the infectious virus after drying it onto the probe. So we know that the virus can be dried and recovered without any harm to the virus, but adding the disinfectant will then deactivate or kill the human papillomavirus, and our results will show that there's no or very little infectious virus left, and we can quantitatively measure that, and I'll show you that in a minute. And then the final one is where we actually use a probe device. We use the probe handle or the part of the probe, and we can dry the virus directly onto the probe and then put it into a system such as the Antigemix system of Germatech or the Trophon device or some other system, show whether or not those disinfectants and those disinfectant systems can actually deactivate or kill the human papillomavirus. And this again will provide very strong evidence of that the disinfectant will indeed prevent the potential for hospital infections due to HPV. Next slide, please. So this is the first published study from our laboratory where we were studying disinfectants. And I want to point out here that we use both our natural infectious virus, which we call here the native virus, and we use these a surrogate virus that people like to use in our field. This one is called the quasi-virus, and this is just to point out that you have to use the natural virus to get the real results. That the quasi-virus, in some cases, will look the same, but in other cases, will give you data that is not accurate for the native virus. So you cannot use a surrogate particle to do these studies. You also have to be careful on how you produce the virus. We've been working on this for almost 35 years. We know how the virus needs to mature and be structurally stable. So the virus we use is at the highest potency for infection, and so we have done many studies to understand these things. So the graph you're seeing here is, again, in our first study, we just took a handful of known disinfectants, things that are found in hand sanitizers, things that are used in hospital situations, and we tested them to see if they could indeed deactivate or kill human papillomavirus. And you can see some of the differences with the surrogate particles, especially if you look at isopropanol, the surrogate particles were clearly deactivated or killed by isopropanol, but the native HPV, it had no effect on it. It did not deactivate or kill the native HPV in any way. The other thing to point out here is if you look at GTA and OPA, this is what I mentioned before, these have been classified as high-level disinfectants. But what we found was that neither GTA or OPA was able to kill human papillomavirus. So again, those definitions came out before anybody could test human papillomavirus. So you also have to consider, when you're looking at your evidence-based practice, has that high-level disinfectant been tested against native infectious HPV? So what we found was HPV-16 is a highly resistant virus, more so than other non-envelope viruses previously tested. The method we use, we tested the surrogate or the recombinant HPV particles, the quasi-virions, versus the authentic HPV-16 grown in three-dimensional organic typic human epithelial culture. We tested the susceptibility of high-risk HPV to clinical disinfectants. The test results showed that the commonly used clinical disinfectants, including those used as sterilants in medical and dental healthcare facilities, had no effect on HPV-16 infectivity. So this made us made us state that policy changes concerning disinfectant use are needed. Next slide, please. So this is a study that we did using the high-level ultraviolet light system, the antigermic system S1. And you can see on the left panel, we're using infectious HPV-16, and on the right panel, we're using infectious HPV-18. The red line is a log-4 reduction in viral titers. That is according to US regulations that require to show a log-4 reduction. And you can see that using the device, we were able to show that log-4 reduction. Actually, if we look at the data closer, we can find no sign of infectious virus remaining after using the device. And we compare that to another positive control, which is hypochlorite or bleach, which actually, again, can cause that log-4 reduction. But if you look in the middle where we used OPA, this has been a classical high-level disinfectant. It didn't even reach a 1 log reduction in this study. So the automated Antigermix S1 device showed excellent efficacy against HPV-16 and HPV-18, whereas OPA showed minimal efficacy. And our results suggest that healthcare facilities use endocavitary ultrasound probes need to strongly consider the disinfection methods that are effective against HPV. And I will point out that this study was done using discs that were made out of the same material that probe handles are made out of. Next slide, please. So our studies, the aim of our study was to test the efficacy of ultraviolet and as a disinfection of both HPV-16 and HPV-18 using the coupon methods. Coupons are discs. Those terms are used interchangeably. And again, they are made out of the same material that the ultrasound probes are made out of. The coupons were, so high levels of HPV-16 and HPV-18 were dried on the coupons, then placed in the Hypernova Cronus AS1V2 device to inactivate the virus. And the HLD Chronos demonstrated a greater than fourfold reduction in either HPV-16 or HPV-18, efficiently inactivated the infectious virus. Next slide, please. So in conclusion, the HPV research that we have done has shown to be a major driver in changing clinical practice, establishing new guidelines, and clinics adopting new technologies such as the UVC HLD. Published research papers show ultrasound probes are a potential source of HPV transmission, posing a new challenge for infection prevention. Not all research is of sufficient quality to inform clinical decision making. Therefore, you need to critically appraise evidence before using it to inform your clinical decision making, i.e., comparing standard disinfection practices to ultrasound probe reprocessing, high-level disinfection practice. The three major aspects of evidence that you need to critically appraise are, and this is the same thing that my colleague Dr. Weber just mentioned to you, is that validity. Can you trust it? Do you understand how they're doing the experiment? Are they using surrogates? Are they using the real thing? Impact. Are the results clinically important? Applicability. Can you apply it to your patient? Next slide, please. So with that, I'll turn it back to the webinar organizers for the Q&A time. Thank you.
Thank you, Dr. Myers, and thank you, Dr. Weber. We're now at the Q&A portion of the webinar. We're going to begin answering any questions you have regarded the presentation. And as a reminder, you can still submit questions through the questions box. Our first question, Dr. Myers, what is the process for a manufacturer to have their medical device tested against HPV, and what is the time frame? And a carry on to that, how do we find out if a company has tested against your native HPV testing protocol?
Well, let me just answer the second part first. That is something you need to discuss with the company directly. That's the way you would find out. Not all things get published, and there are things out there that have been done but haven't been published yet. The first part of the question is, what we do is we have a discussion with the manufacturer. We try to figure out what their needs are, what they want to be able to show, and then we form a protocol with their desired results, but also including controls so that we make sure the validity of the results are correct. And then once we have the protocol approved, we go ahead with doing the study. Once we have all that done, it could take 2 to 4 weeks for us to finish the study.
Thank you, Dr. Meyer. Our next question is for Dr. Weber. What should you look for, or how do you determine if the incorrect research methodology has been used?
So I think that's obviously a bit of a complex question. I think what you do is you apply standard, appropriate epidemiologic tools that we teach in our School of Public Health and otherwise. First, you have to start off with, as Dr. Maya said, you have to use the right research technology. That is, to measure your microbes and killing, how you get them off the surface, whether you're looking at HPV or Staph aureus. That's really where you need an expert microbiologist to review the data. Hopefully, if it's a good journal, you've had an expert microbiologist look at it, somebody like Dr. Myers. That's the first thing. Then you have to look at the design. Did they mimic actual practice? Did they do enough repetitions? As with any study, if you're putting inoculum on something, you want appropriate positive and negative controls. That is, you want to contaminate some devices and not put them in a disinfectant, make sure that you can get the organism off. And you want some negative controls where you run it through your system. They should have, if you've not inoculated them, there should be no pathogens. And so you know you're not contaminating it in your system. So you want those appropriate controls. You need sufficient numbers to be statistically meaningful. And then there are things you want to use relevant pathogens that you would see in healthcare. So for what we're talking about, ultrasound probes, starting with vaginal and rectal ultrasound probes, you want things that would mimic, don't have to be the exact organism, but would mimic syphilis and gonorrhea and chlamydia and other vegetative bacteria. You clearly want envelope viruses that are herpes simplex or would mimic them, and non-envelope viruses. And here, because they vary quite a bit, I think you would clearly want to show that the device or disinfectant was active against HPV. So you need to look at all of those factors in assessing whether the article is in fact valid.
Thank you, Dr. Weber. And as a reminder, if anyone has any questions, just type them into the questions box. Our next question, when a disinfection system is modified, does its efficacy need to be retested?
Repeat that again. I didn't quite
Sure,
get the question.
certainly. Sorry, Dr. Weber. And this may be for either of our speakers. When a
Yes.
disinfection system is modified, does its
Yes.
efficacy need to be retested?
So the answer in general is yes. It obviously depends a little bit on what that modification is. So for instance, if the modification was that you added in a new warning bulb or light that indicated that time hadn't been reached before, that might have been on the paper process measure, some tape that was used, and you add an extra warning light, that probably doesn't need to be revalidated. Obviously, if you change your device and you go from a device that has a chamber size of, say, it's just as an example, it's 15 centimeters by 15 centimeters by 20 centimeters, and now you make a device that has 3 times the chamber size, or you change the configuration in the chamber, or you change the intensity of the UV bulbs or the gas concentration, then you need to revalidate the device. Generally, these devices, of course, are approved by the regulatory agencies in different countries, and you would follow the rules those regulatory agencies have for when you need to revalidate the device. But you're right, you couldn't assume that a device made for one application, if it changes in important parameters, would be safe.
Thank you, Dr. Weber. Our next question, we use Trophin 2 for disinfection, and has it been tested to be effective against HPV yet? And that would be to either of our speakers.
So I will defer to Dr. Myers. The answer is I, off the top of my head, am not aware of the literature for that particular device against HPV. Dr. Myers may have more information.
I think it's what I said earlier, you have to talk with the manufacturers. I mean, that's the key. You have to hold a conversation with them.
Thank you. Our next question, is the test against HPC recognized as a standard to evaluate disinfection? Oh, sorry, my apologies, HPV. I'll repeat that. Is a test against HPV recognized as a standard to evaluate disinfection?
From my point of view, I think we're still in the early eras. I think as for the basic laboratory study, we try to do all the proper controls. We try to use all the proper materials. We do the, we repeat the study over and over again. We use different batches of virus. We use different batches of different disinfectants, if that's the case, And so from basic laboratory study, we're doing all the things that would be required to show that our studies are valid. Now, in the clinical area, this is more of Dr. Weber's area, but I don't think that any group or government has yet said this is the standard way we test against HPV. I've not heard of it. I don't think it exists yet. So I think the conversations are continuing, but from what I know, nothing has been written down and said this is the way you have to do it.
Thank you, Dr. Myers. And just a final reminder, if you have any questions, to type them into the questions box. As of now, all the questions we have been asked and answered. So with that, we would like to thank Dr. David Weber and Dr. Craig Myers for your presentation today. And on behalf of the Germatech, who sponsored our webinar, we'd like to thank you for taking the time to join our session. As we don't have any more questions, I'll end this session, and we hope that you enjoy the rest of your day. Thank you.